We'll get started in just a minute. Okay. Well, it is my pleasure to welcome you all to Columbia Ethics Grand Rounds. I'm Sandra Sujin Lee, Professor of Medical Humanities and Ethics and Chief of the Division of Ethics here at Columbia University. I am absolutely delighted to welcome you today to our Grand Rounds entitled Care, Coercion, and Responsibility: Ethical Challenges in Mental Health Care. For those of you who are new to Ethics Grand Rounds, this is a monthly series that is organized by the Division of Ethics in the Department of Medical Humanities and Ethics at Vagelos College of Physicians and Surgeons at Columbia. The goal of Ethics Grand Rounds is to engage our community of health professionals, scholars, scientists, and trainees across disciplines by centering important topics and debates in medical ethics that relate to clinical practice, research, education, and community outreach. Our hope is that attendees will leave each session with a greater understanding of the ethical and social implications of the topic of focus. This series is supported by a dedicated organizing committee of faculty and division staff to whom we owe a debt of gratitude. Before I turn to our topic for today, I'd like to remind everyone online to please check the chat for logistics and other information for this session. Following our speakers' presentations, we will move into the discussion portion of today's session, where we hope that you will enter your questions into the Zoom Q&A, and you can find that at the bottom of your screen. Please remember to keep yourselves muted. We are recording today's session, and the recording will be uploaded as a resource to the Columbia Division of Ethics website following this event. So now for today's session, we are absolutely delighted to be joined by two experts in the field. We will hear first from our moderator, Dr. Stephanie Lamel, who will frame our session today and who will introduce our speaker, Dr. Ashwin Vasan. Dr. Lamel is Director of Public Psychiatry Education and Professor of Clinical Psychiatry in the Department of Psychiatry here at Columbia University and also at the New York State Psychiatric Institute. We are looking forward to a very rich discussion today, and I'm very happy to hand it off to you, Dr. Lamel.
Great. Thank you so much, Sandra, and good afternoon, all. I'd like to go over a couple of things that I'd like us to hold on to and consider during the presentation today. The first thing I think that we need to think about is addressing our social bias that affects how we think about people who have serious mental illness and folks that are homeless and folks who may be involved in crimes. And so I want to disaggregate these three things and think about them separately, because these are three distinct issues that require unique approaches for prevention. So first, when we talk about homelessness or people who are unhoused, only about 17 to 25% of unhoused people have serious mental illness. And the leading causes of being unhoused or homelessness is poverty and inability to pay rent or mortgage and the limited supply of low-income housing. Part of this is also that most people are intermittently homeless, meaning that they lose their housing, but then they quickly get rehoused. But people with serious mental illness make up the majority of the chronically unhoused, and particularly the chronically unsheltered unhoused people. So when we're thinking about this population, we really have to think about treatment that's linked to housing. One of the other things that we're going to be talking about is violence or crimes. And only 3 to 5% of violent crimes are attributable to serious mental illness, which means about 95% of violent crimes committed are not attributed to serious mental illness. And there's a lot of more recent work that looks at this, and we'll be discussing this more in the presentation. Violent crimes are associated with socioeconomic disadvantages like poverty and income inequality, high crime neighborhoods, firearm availability, and substance intoxication. And these are things that people who with serious mental illness who actually commit violent crimes have in common with other people who don't have serious mental illness who commit violent crimes. People with serious mental illness, however, are overrepresented in our criminal legal system. This is because people with serious mental illness are often arrested and incarcerated for low-level misdemeanors like shoplifting, loitering, disturbing the peace, and public intoxication. So we often think about people with serious mental illness as committing crimes and being in the criminal justice system, but these are really for low-level crimes, not for the violent crimes that we often associate with people with serious mental illness. The other thing to take into consideration is that there's a significant amount of trauma whenever we're talking about violence, trauma to the victims, trauma to the perpetrators, and that people with serious mental illness are 2.5 to 10 times more likely to be victims of violent crime as opposed to perpetrators of crime. Women with serious mental illness have even higher rates of victimization. And these violent acts take place in communities, they take place in healthcare institutions, and in the criminal legal system. So there's definitely an overlap between these issues, but from a public health and public safety perspective, we need to first understand the causes of each of these separately without bias. The second thing I'd like us to think about is that the mental health system has become the default system to manage public health and public safety. There's no other specialty in medicine that has been, in quotes, blamed for the circumstances of unhoused people with mental illness and complex social needs. Additionally, mental health care systems are dramatically underfunded, and so much so that we've required parity laws to address the fairness and reimbursement for mental health care. Because of these shortages, there are staff shortages, often due to low salaries and an increased demand for mental health needs. This too is related to social bias and stigma against people who have mental health needs. It has resulted in an unrealistic expectation that we as a society have that somehow the mental health care system is going to be able to accomplish and fulfill all the needs of this population that we'll be talking about today. So what are some of the ethical issues that we need to consider? I'm going to name a few ethical concepts. So one is autonomy, which is the right to choose. Another is beneficence, duty to provide care. Another is non-malfeasance, to do no harm. So we need to take these three concepts and other ethical concepts into consideration when we suspend people's right to decide for themselves, take away their autonomy. And when we mandate people to medical care, beneficence, in a system that has limited to no authority to address their social determinants of health. We are often re-traumatizing people, non-malfeasance, who are already reluctant to engage in our systems of care. And in that re-traumatization, people are even more reluctant to come and engage in care voluntarily. Fourth thing that we need to think about is that we also can't ignore the complexities of New York City politics, the New York City criminal legal system, funding streams for healthcare in general and mental health care in particular, and the lack of centralized infrastructure to our healthcare systems in trying to coordinate this with other social services systems within the New York City limits. So to ethically address homelessness, violence, and care for people with serious mental illness, we need to understand these ethical issues and how this overlays with social justice, social determinants of health, and serious mental illness. So let's hold these ideas as we engage in today's presentation. So it's my pleasure now today to introduce you to Dr. Ashwin Vasan. Dr. Vasan, MD, PhD, is an internist, epidemiologist, and health policy expert with a national reputation for driving innovative public health solutions. He is currently a senior fellow at the Yale School of Public Health and an affiliate faculty at the Jackson School of Global Affairs. As New York City's health commissioner and senior public health advisor to New York City mayor from 2021 to 2024, he led the city's recovery from COVID-19 and launched Healthy NYC, an ambitious, data-driven initiative to raise life expectancy to a historic high by combating preventable premature deaths. So it's with my great pleasure that I now turn this over to Dr. Vasan.
Hey, hello everyone. I believe I'm unmuted. Now I'm just going to struggle to get my presentation up, but I want to first start by thanking Sandra, thanking the Division of Ethics for having me here today, and to Stephanie for taking time to moderate this discussion. It's great to have someone in dialogue with me today who's been there and who's cared for patients for decades and who sees the complexity of these issues firsthand. Um, I want to, as I get the presentation up, I want to talk a little bit about my own journey and how my views on these issues have evolved. This is not a clean, simple issue. This is an issue that is, if it has one defining feature, it's complexity, and it's why we haven't found durable solutions for decades since the decline of institutionalization, starting in the late 60s and accelerating into the 70s and 80s and beyond. Sorry, I'm just struggling to get my presentation up. Just one second. I think I have to do a slideshow. Is that right? You all see that, yes? But now I can do a slideshow. Hold on one second.
From the beginning.
From the beginning, yes. Let me see what I can do here. Do I know what I'm doing? It is working. Ah, brilliant. Success? Very good. Very good. Okay, thanks. Um, so I see this, my views on this have evolved over time, not because my starting point has changed, which is always with a bias towards the most vulnerable, towards people who are directly impacted by illness. My career has been on that arc since the beginning. I started my career um, it's more than a decade working on HIV programs in some of the hardest places in the world with some of the most vulnerable people in the world, and always with a bias towards their needs first, not government's needs, not private sector needs, not clinical needs, but rather their human needs first. I then had the pleasure to lead Fountain House, a vanguard model in serious mental illness for 3 years. And for those of you who are not familiar with it, it's really a residential, non-residential community psychosocial rehabilitation program, but that doesn't really do it justice. It is an anchor. It is a life vest. It is a safe harbor for people who find the world in many ways so unwelcoming and so stigmatizing and so biased against them that finding this safe harbor, finding this community allows them to reach their potential and allows them to recover from the depths of serious mental illness. And so, as my roles have increased, as my responsibility has increased, I think that's where I've started to take on more of the complexity of these issues, and most recently leading the largest municipal mental health system in the country. What that entails is that you have to see the entire picture. And that means there are other stakeholders in this conversation besides the clinician, besides the patient. And as you know, serious mental illness and its intersections with substance use and homelessness, um, we would be remiss if we didn't say clearly it does have social ripple effects. It has ripple effects beyond the person. It has ripple effects on families and communities. And as we'll talk about, it is uniquely, however rarely and however misrepresented it is in the public, it is one of the few, if not the only set of conditions. And I'm referring mainly to conditions associated with psychosis and mania and disorienting, disabling mental illness. It is one of the few conditions associated with violence in the way that it is. Now, Stephanie started with a couple of accurate statistics, which is that the way that the public perceives this problem and its actual epidemiologic burden and its actual intersections with public safety and violence and homelessness are much smaller than is played out in the public discourse and the sensational headlines that you read in the New York Post and the Daily News and all over the internet. In part, I think, I used to just look at those headlines and say, oh, let's just dismiss that. That's just sensationalism. And indeed it is. It is not grounded in population data. It's not grounded in a fair discourse on risk. But what it is grounded in is a deeply human reaction. And yes, it's a stigmatized reaction, it's a biased reaction, but it is a human reaction to how untreated, disorienting, disorganized, chaotic symptoms of serious mental illness displayed out in public make people feel. And the truth is, like, we all have to ask ourselves deep down and genuinely, what do you feel when you see someone in crisis on the street? Do you feel safe? Do you feel like you know what to do to help? Do you feel like you just want to walk on by and forget that ever happened? Because that's the majority of what New Yorkers and Americans and people feel. They don't know what to do. They might feel a little bit scared, and they just want to walk on by and pretend it didn't exist. And they want it out of sight, out of mind. That's not a particularly humane reaction, but it is a human one. And it is one that, as a public official, you had to keep in view. Unlike working with Fountain House or working as a clinician, where I could laser focus on the needs of the individual and the patient and the community, as a public servant, you have to keep the entire view. And so I just want to orient us there because that's the complexity of this problem, is that there are other stakeholders here. And this is, however rare, one of those conditions that has ripple effects on those stakeholders, both in reality and in perception. And we need to use data to close that gap and try to build something better. But these statistics are good grounding, but they are often used in defensive mode, right? When we feel like the people we care about and the patients we care about, and our loved ones with serious mental illness. And I come from a family that's been impacted by severe mental illness. So this is very personal work for me. When we feel like our loved ones or the people we care about are being attacked, we use these data to try to say what these data tell us is you're blowing this out of proportion, or that this is not comporting with or consistent with the reality of the risk. And while that is important for us to do, grounded in the data, it doesn't always assuage people, right? And that's an important truth. We need to hold that tension, even if there isn't any clear resolution. Now, in 2022, early 2022, late 2021, this is the situation we walked into. The overdose deaths were at a record high. Unsheltered New Yorkers were at a record high in recent years. Obviously, this is, still with the pandemic raging. People living on the subway and, of course, felony assaults on the subway were at a significant increase to pre-pandemic levels. And meanwhile, hundreds of psychiatric beds were closed during the pandemic and had not been reopened at that time. And as Dr. Lamel alluded to, the mental health system is often asked to catch the byproducts of systems failures, both upstream from it in terms of poverty and social determinants and trauma and insecurity, but also from other systems in parallel: housing, criminal, legal, substance use, and the overall social safety net. Meanwhile, within the first few weeks of my appointment, we had the tragedy of Michelle Go being pushed onto a subway track by someone who had untreated serious mental illness and who was cycling in and out of our systems and who we had failed to engage and care for adequately multiple times. And I had the privilege and also the difficulty of meeting her family and seeing that impact too. That is a social impact that we have to acknowledge. We cannot dismiss it with data. The pain of that family is real. Again, however rare, it is still real. And for us as as people who care about solving social problems, care about health, care about our city, I think it's essential that we keep those stories in view as well. On May 22nd of that year, we had another tragedy on the Q train with Daniel Enriquez fatally shot. And then, of course, a year later, we had the tragic, I would say, murder of Jordan Neely on the subway, and his killer, Daniel Penny, acquitted then last year for his murder, which only tells us that the story of untreated serious mental illness, the story of it and its intersections with homelessness, its intersections with public need, and its intersections with the public writ large are often stories of tragedy. And it's critical for us to see that tragedy in all of its complexity, um, but also to think what are the root causes at the individual level and what are the systems failures at the government and non-governmental level that lead to these interactions. I talked about what New York City lost in terms of psychiatric beds. And this is part of a long-standing, of course, decline in psychiatric bed capacity nationally as well as in New York State. In the pre-pandemic era, um, and during the first years of the pandemic, an additional almost 1,000 beds went offline. And thanks to work from the prior administration and Governor Hochul, through some really strong lobbying with the hospital systems, because remember, these are not beds that have strong economic incentives to keep open, right? They're very hard to pay for from a hospital administration perspective. And so it was very easy from a brass tacks profit and loss perspective to justify the closure of these beds. But I give a lot of credit to Governor Hochul for really pushing hard to get these beds reopened. And today, um, we had almost 700 beds, 640 beds restored under Governor Hochul through last year, and we've added an additional 350 odd beds across the city. So there is more capacity coming online. And look, beds are not the solution to the overall crisis, but it is important that people in crisis have a place to go where they can get medical and psychiatric care, and where that care can be extended for the appropriate amount of time to stabilize. We know that in 48 or 72 hours in an emergency room, this is not going to happen. And that's why we see the cyclical revolving door within our emergency rooms across the city, is because often there isn't inpatient bed capacity, and there isn't, even when there is an inpatient admission, every incentive is to discharge that patient quickly. So these are just some of the systems forces that we all need to be accounting for. And some of you watching this probably come from this system and are very familiar with that. We launched a mental health plan in early 2023 that we spent a year working on. We spent a year crafting a sound, smart, comprehensive plan to address the mental health crisis across three prongs: overdose, children and families, and of course, serious mental illness. The first time that serious mental illness was really centered in our mental health strategy in this city. The big criticism from the de Blasio administration was that Thrive NYC, despite all of its spending, $1 billion of spending, gave very little focus to people with severe needs, invested so little in the programs needed around crisis response and around addressing people with psychotic illness, manic illness, and so forth. And we said, no, we need to make that central. But what happened is the politics preempted us. Clearly, there were people in the administration and supporters outside the administration who wanted to use a law and order approach to say we're doing something about serious mental illness and street homelessness. And so in November 22, as we were really finishing up our mental health plan, the directive coming out of City Hall to the state was to expand the legal definition of basic needs in order to increase the number of involuntary removals from the street. Um, this dominated attention, as you might imagine. It's a very controversial approach, and certainly on its own felt incomplete. And yet it obscured all the other good works we were doing in mental health across my tenure and across the administration, including more than $1 billion mobilized across agencies to address the needs of children, people with substance use, and serious mental illness, including an expansion of clubhouse programs, which hadn't happened in 30 years and has now led to the state putting in its first dollars into clubhouses in its history. Um, so disappointing, to say the least, that a sound and comprehensive plan that was crafted with care and thought and with community consultation was preempted by a political, short-term political calculus. And frankly, as you might imagine, without building that supportive system, without building a community-oriented system, removing people off the streets in the main is largely a bridge to nowhere, right? It is simply a bridge to a hospital for a short stay and right back to the same conditions. And so this policy can only be regarded as fairly ineffective. But what do we agree on? We agree, and I think there's quite violent agreement that, no pun intended, that we want a recovery-oriented mental health system, that we want a mental health system that centers not just symptom management and medication, but that people with serious mental illness can live with purpose, that they can regain the ability, in some cases, to work, to go back to school, and at a minimum, to find community and belonging. That we build a system where housing, and particularly housing first, is considered infrastructure, where the conditions to recover require the sine qua non of recovery is having a roof over your head. And that sounds like common sense. And we piloted housing first um, in partnership with DHS in my first summer. We put 80 units out there as a pilot in Brooklyn, and it was a success. It just didn't have the follow through and didn't have the funding. Um, that we focus on not just crisis response and not just these moments punctuated when a person is not being treated, not on medication, not engaged in care, and where their social needs are not being met, but that we talk more deeply around a sustained continuum of care across months and years through sustained engagement, whether that's ACT teams or mobile crisis teams, um, and certainly integrated physical and psychiatric care, where we talk about community as therapy, where we talk about social isolation as a symptom that needs to be combated in and of itself. And models like Fountain House and Clubhouses, like others, are essential anchor organizations, anchor models within this community mental health system, that we build a system that focuses on procedural justice. In the situations where mandated care or coercion is used, we must ensure that it's used with a fair process, with voice and with respect. And those are also clinical obligations, not just simply um, the act of providing care, and that we build a system that is focused more on accountability. Had I stayed longer in my role, I would have built, and we were in talks to build, a model similar to what LA County has built, which is a performance-based mental health system where payment to contractors, to nonprofits, to clinical systems is contingent upon their achievement of outcomes. And those outcomes mean not just process outcomes, the number of visits you had and the number of phone calls you placed and the number of referrals you filled out, but rather, how are your patients doing? How are the community members you're serving actually doing? Not and we have a system right now that's focused mainly on two things: the number of clients you're serving and the number of touches, the number of times you interact with that client. That is wholly unsatisfactory. We agree on the destination. What we don't agree on, I think, and what I mean when I say we, not you and I, but rather as a whole, where we have debate is, while we build this system that we all know we need and want, where we aren't relying on hospitalizing and punishing and criminalizing mental health and homelessness, while we do the hard work of building that, what are we willing to tolerate in the meantime? What are the conditions we are willing to accept for people with serious mental illness, for the communities in which they live, for the family members that are suffering as well, and of course, for the rare but tragic victims when there is the intersection with violence. And this is really a huge question because we know that there are some uncomfortable truths. We've had a supportive housing pledge, for instance, of 15,000 units over 15 years, 1515. We're not even close. We're barely a quarter of the way through that pledge. Why? Well, I think there's a lot being written about why housing is so hard to build, why this kind of housing in particular is so hard to pay for. And often it's not just the housing, right? It's not just the physical structure, it's the services and how much we reimburse for those and how much we pay nonprofits for that care. I'm going to try to stay on time. Meanwhile, we slowly have expanded programs like clubhouses, but we don't have enough. We haven't leaned enough into expanding our clinical workforce and paying our clinical workforce, but we don't have enough clinicians. I mean, that's a truth. We don't train fast enough, and they're not deployed fast enough. And the majority of psychiatrists in the city still work in private practice. Now, some of them work in hybrid. They would do some time in private practice and some time in public practice. But for in the main, the majority of psychiatrists in New York City are not working in public psychiatry. And that's a problem because we haven't created the incentives and the conditions for them to do so. So while we've known what's needed, while John F. Kennedy, frankly, outlined what a community-oriented mental health system might look like in 1963 when he launched the Community Mental Health Act, it's never been built. It's never been fully resourced and invested in. And meanwhile, people are suffering on the street, and there are social ripple effects. So there are these two major positions that we cannot abandon people in care who need care, that the focus only and exclusively on voluntary approaches is effectively a denial of treatment. Um, and leaving people to deteriorate in the name of autonomy, one of the key principles, risks what Treffert called dying with their rights on, right? This is a real debate. Like the ability, Tom Insel, who was the head of NIMH, who's a friend and a board member at Fountain House, talks deeply about an experience he had in LA, working with a community mental health program, a street psychiatry team that walked by a woman, an older woman who was clearly having florid psychotic symptoms and unable to accept care, unwilling and unable to accept care. And so time after time they came by and they came by. And finally she was hospitalized. She was hospitalized for a medical condition, actually. And that put her in the ICU. She was septic and she got care. And eventually she got, in the process of that long-term admission, she got psychiatric care and she got stabilized. And he ran into that patient actually at a conference because she was a patient advocate in the following months after her recovery. And she cursed him out. She cursed him out and said, "You walked by me. You walked by me every single day. And you just walked away." And so that, there is the tension here between a voluntary approach and when does that end and fail? One of the things we don't talk, we'll talk a little bit about assisted outpatient treatment, but this is a real issue, and we need to think carefully about how we apply those programs and how we apply those tools judiciously, fairly, but effectively. Nearly 40% of people with SMI received no treatment in the last year. That's a national figure out of SAMHSA. And when implemented with supporting services, AOT can have real effects. It's very different across the country. It's very different depending on which states and which places have made investments into those supportive services. But make no mistake that the judicious use of mandated care in the outpatient setting um, can help stabilize a person who's failed to engage in care, has had multiple hospitalizations in the past 2 years, or has a history of violence. And in the Duke study that we'll talk a little bit about, 75% of participants in AOT helped them retain some self-reported control of their lives. There are huge equity issues embedded in this. Dr. Lamel talked about how Black and brown New Yorkers are overrepresented in both the mental health system and the criminal legal system. They are also overrepresented in AOT. Now, is that a program design failure? Is that an upstream systems failure? Is it both? These are questions worth asking. But there's no doubt that the application of these mandated tools and coercive tools are largely applied to people of color, in this city at least. The other issue is, of course, that you have to fix the other position, I should say, is that, stop focusing on the individual and let's focus on fixing the system. And it is true that 40% of people with SMI have experienced an ER visit in the last 6 months. Almost 70% have ongoing unmet mental health needs. And while sheltered, 1/3 experience violence, which will drive a person out of shelter, right? We are a city with a right to shelter law, Callahan, which mandates a person's right to a government paid for bed, a government funded bed, every single night. And yet, shelters, as many of you know, are sometimes pretty unpleasant and unsafe places to be, particularly if you are living with serious mental illness and substance use disorder. We know that housing first can work if applied fairly and applied widely. Houston is probably the best example of a city that has adopted that at scale and seen dramatic reductions in its homeless population, both living with and not living with SMI. And it's obvious and clear that compulsory treatment alone is a weak option, just as involuntary removals is a weak option. That subjecting someone to mandated court-reported treatment that has a ratio of something like 85-1. In order to get one hospitalization down, one crisis episode down, you need to have 85 people in care. That's not a particularly effective ratio seen in isolation. So engagement is a very hard issue for people with untreated psychosis, with anosognosia, with lack of insight, the inability to sort of understand what your needs are or to communicate that. So this is a very challenging population to engage regularly. And what happens to them in the meantime is a big public health challenge because we know that people with SMI on average live up to 25 years shorter lives than the general population. So as I said, the coercion alone does not work. We know that housing first works up to 50% reduction in ER visits and hospitalizations under housing first programs. And we know that mandates plus services have pretty significant results, at least in New York itself. This is the Duke evaluation that was done in partnership with New York State OMH. It's now 20 years out of date. So it's time to refresh that. It's time to really look at this again. And when I was, commissioner, we saw a lot of issues with our AOT program, not so much in the work of the AOT clinicians and the workers, but really in our intake and our eligibility programs, our supportive programs, that our wraparound services. And Kendra's law in AOT in New York State is very narrow. It only mandates the patient to receive psychiatric care and medication, which, as we know, medication and psychiatric care is just one pillar of a multi-pronged pillar of stability that includes housing, that includes community, and that includes economic security and opportunity. So, let alone primary care and attending to co-occurring medical needs. We started with those statistics that Dr. Lamel lingered on rightly as overall averages to try to put the issues of serious mental illness, homelessness, and violence in context. And yet we know, and she alluded to, that politics doesn't always operate on that level, right? Politics often takes subpopulation issues and amplifies them to become mainstream issues. Rightly or wrongly, that is that is the world of politics. It happens even now, right? It happens who you choose to cast your gaze on and to focus your policy gaze on is a choice. And we are seeing a new administration focus their gaze on a different set of New Yorkers, and that's fine. But let's just be honest that the overall picture is not always the one driving public policy. And so while it is a small subset, and frankly, when it came to what we were focused on at the city, we were really drilling down on the order of maybe 2,000 patients across the entire span of New York City who had multiple touches with our crisis response system, who had multiple hospitalizations, who might have had histories of substance use and violence, and that were street homeless, that were unhoused. This is a very small population, and yet it is a population that requires an intensity of public policy solutions that outweigh its population impact. And for that small subset, I want us to just, again, be really honest that the claim that not all people with serious mental illness are dangerous is true. But there is a specific and small subset of people with untreated psychosis, untreated mania, and anosognosia that can be dangerous. And the data, the subset analyses do show that there are higher odds for that small sliver. And so, do you design public policy for the broader population? Do you design public policy for the narrow? These are the challenges that you face when you're trying to tackle this issue. And there are no simple solutions here. So when we talk about an ethical frame, autonomy, beneficence, non-maleficence are the key. The patient triad that we all learn in medical school, that we anchor our work around. The fourth principle is justice, one that brings in a wider frame. Justice to whom? Justice, of course, to the patient. Who's lifting up the social and clinical justice for that person? But when you start to look at the fair distribution of risk and the fair distribution of benefits and burdens, it at least in a position like the one I held, it's impossible to ignore the ripple effects on third parties. And so this is where the community enters the frame. And I would argue that in addition to these four ethical principles, that one must apply these five conditions to looking at any program. Of course, its effectiveness, its proportionality, and this is a big question. Is coercion and mandates, are coercion and mandates proportional to the actual risk? One might say no based on population data, but one might say yes based on the subpopulation data. And it's a question of, again, where you're casting your gaze and what you're anchoring on. Necessity, can the same outcome be achieved through less restrictive means? And this is the challenge of voluntary, where the line between voluntary and involuntary care breaks down and becomes very, very challenging from a public policy perspective. Least restrictive means is always the preferred option. Voluntary means is always the preferred option. But what happens when you've failed time and again with voluntary means? What do you do? Is it causing the least infringement on a person's rights, civil liberties, and how much? And of course, public justification. There are people who are burdened by the community impacts of serious mental illness in addition to the patient, families, community members, and yes, for that small population, members of the general public. There has to be a lens in which that is in the calculus, but not driving the entire calculus. And I think that's where our stigma plays up, is that we sometimes allow public justification to drive the entire envelope of work. Let me stay on this for just a moment and let's talk about harm. One cannot doubt the harm that criminalization of mental health causes, whether it's forced removal from the street, whether it's police-led crisis response. We've seen, I mean, I was at Fountain House, which had a tragic death at the hands of the NYPD in Deborah Danner, who was simply having a psychotic episode in her home and posed no real threat, but lost her life. Win Rosario, last year. Um, the recent one, I think there was a recent one earlier in 2026. So this is a too common story, right? This is all too common story that when you bring a a criminal justice first approach, a criminal legal approach first, that you often end up with these unintended outcomes. Um, that said, it's also an extraordinarily difficult situation for our police, and the police are saying very clearly to us in public health, we don't know what to do. We're not well trained. Get us out of those encounters. And so this is once again is like, where does that break down? Where does that responsibility break down? I would love to have a system of entirely non-police crisis response. Is that safe? Is that the right thing to do? Is the data from Eugene, Oregon that everyone bangs our heads over, that tiny little place, is that applicable in New York City? I don't know. I mean, to be perfectly honest, I don't know. It hasn't worked yet. Be Heard and some of our non-police responses have not produced the kinds of system-wide outcomes that we'd like. And it's not just a question of scale. It's not just a question of throwing more money at the problem. We know that criminalization is also injurious long term. Our largest treatment facilities in the country are jails. County Jail in LA, Rikers Island, Cook County Jail in Chicago. And of course, over time, the more encounters you have like this has long-term injury and harm to yourself, to your sense of self, to your sense of agency, to your autonomy, and of course, to your overall well-being. Now, let's talk briefly about the wider harm. There's harm to the person. We talked about life expectancy declines. There's harm to family. And this notion of ambiguous loss, like having a family member, and I've experienced this myself, the notion of having a family member who's lost to you, but who's there is an extraordinarily painful experience for anyone who's ever been through it. And of course, cascading harms and traumas across generations, again, something that I've experienced personally. And yes, this very modestly elevated risk of violence is something that cannot just be glossed over. It has to be dealt with from a public policy perspective. It cannot just be shoved under the rug. It has to be dealt with. And at least there has to be clear explanations about why we're not doing something about it. And there is fair debate around what to do. And I think we'll see more and more of this conversation come to the foreground as the new administration builds its Department of Community Safety. The experience of coercion, there was a pretty famous MacArthur coercion study from now 30 years ago that basically the take-home message is that how coercive means are used really matters. It's not just the act of coercion itself, it's how much participation the person had in the process. Were patients heard? Was there any respect given and dignity given? It's very hard to give respect and dignity on a moving train, and I have to tip my hat to the DHS workers and my health department clinicians who go out every single night and engage people on the subway and out on the street with kindness and dignity and with respect. It's very hard. It's very, very hard to maintain that at all times when you're dealing with people with florid psychosis and with trouble with insight. And is there a belief that this was done in good faith, that this wasn't just done to remove you from a particular location, but that this was done to engage you in services, to really, with your own well-being in mind? And there is a way to do coercion that is, again, in its very small and narrow application, in a way that's more humane than not. Almost done. What does the data tell us about Kendra's law? Well, it tells us that when paired with services, that it can lead to not only substantial reductions in hospitalization, this is assisted outpatient treatment, reduced rates of incarceration, homelessness, and increased medication adherence. What it doesn't do, this Duke study doesn't do is attribute the improvements to the mandate alone. That coercive tactics cannot explain improvement on its own. And that is true. Anything narrowly done without supportive services, without addressing root causes, is incomplete. We've said this before, but the mental health system is being scapegoated, and we would never ask another system to catch all of these social problems. What calls structural competency is something that seems to be notably absent in mental health policy across this country, and largely because particularly SMI policy has been punted time and again from the federal government down to states, and principally is led by localities, cities and counties. What actually works, housing and community as treatment. We won't belabor this, but these are just studies that show the New York City Pathways to Housing program, Housing First programs, and therapeutic housing programs in Canada, associated with much better retention outcomes and housing outcomes. Closer to home, we have two good models that are being led by our public hospital system. The extended care unit, which started in 2020 and now has multiple sites, about 70 beds, 65 beds system-wide, has about a 50% reduction, or 50% of extended care unit patients. These are people who can stay in inpatient admission for up to 120 days, are connected to permanent housing within 6 months, and a more than 50% reduction in ER visits and psychiatric hospitalizations. Also, the Bridge to Home program, which was started last year, about 7, 8 months in. And this is a small scale pilot of single SRO style rooms with on-site psychiatric nursing, social, and peer care. And there's 100 beds planned. Evaluation is still ongoing, but it shows that when we put housing at the center of solutions to recovery, that we can deal with the clinical ups and downs and the complexity of someone's serious mental illness. I can come back to this in discussion, but I just want to end here. I hope that in the process of this discussion today, that we can talk a little bit about who is least well off by serious mental illness. And serious mental illness is principally a disease that takes away someone's not just health, but sense of connection with themselves, with others, with their community. And I've heard serious mental illness in some ways, in its worst form, equated to things like, neurodegenerative diseases, not in its pathophysiology, but in what it steals from you, which is your ability to be fully human in the moment, to be fully connected to other humans, which is such a existential part of what defines us. And I always go back to this quote from Ellen Sachs, which is how a society treats its least well-off members speaks volumes about its humanity. And I think I've brought in my notion of where pain lives in serious mental illness. The majority of the pain, of course, lives with the person living with the disease. But to deny that there is externalized pain and to not think about that in designing public solutions is to create a public health ethical frame that is too narrow to capture the complexity of this problem. So I'm eager for a discussion. I hope that I've given you a window into sort of how one might see this problem, having gone from community-based care all the way to the highest levels of local public service. Thank you.
Thank you so much, Ashwin. Terrific presentation. And we actually have some questions in the Q&A box. I'll start with this one. This was sent in by Ellen. She says, this is excellent. Glad to hear the use of the term anosognosia, which I found very few healthcare providers known, including those who work in psychology, a neurological condition that non-mentally ill people suffer from. I wonder why Dr. Javier Amador is not better known. His LEAP method is very helpful. Also, I found guardianship, even emergency or temporary, is underutilized. So do you want to comment on that, or
Yeah,
comment on that as well?
One of the hardest, yeah, I'd love you to jump in as a psychiatrist. I only can say, having participated in the care, I should say, of people with severe mental illness and lived with people with severe mental illness, it is one of the hardest. As I said, it steals your humanity, and one of the ways it steals your humanity is by stealing your ability to connect with others. That's why we call it behavioral health. It steals your behavior. And anosognosia, the inability to recognize that for yourself, to look inward and to have insight, is one of the greatest thefts of serious mental illness. Luckily, it's not a permanent state in most cases, but I'm glad that resonated for you. And I agree with you on the guardianship point. And there are efforts actually to accelerate and streamline the process of guardianship so that families can play a bigger role in the support and care for people with serious mental illness. One of the hardest things that families have to deal with is the inability to make decisions for your loved one. So I agree.
And I'll just add to that that anosognosia, which is also sort of, as Ashwin is saying, is people's ability to understand that they have an illness and that they're experiencing symptoms. It is true that people often that have this don't believe that they're mentally ill, but that doesn't mean they don't have capacity about other issues in their life,
Yeah.
like what they will accept in terms of treatment and care. And there's something that's called PADS, or Psychiatric Advance Directives, which is kind of like a healthcare proxy sort of thing, where people can actually, when they're feeling well and are able to make decisions for themselves, um, self-determine what they want, what they don't want, where they want to be hospitalized, what medications work for them or haven't worked for them, or even whether they have a mental illness or not, but would actually accept care. So there are ways to address this. And guardianship, unfortunately, is often a last resort, and we want to try to do this before we get to that point. Okay, thank you for that question. Dwayne writes, how can involuntary institutionalization lead to successful independent living in the absence of affordable housing? Good question, Dwayne.
Great question. And my argument is it cannot, right? There is not a world in which either on the front end of a crisis and attempting to treat someone in the community and stabilize them in the community, or on the back end of a crisis when they are leaving hospitalization and extended hospital stay, where housing cannot be at the center or is not at the center of that recovery. And so the affordability crisis we see in New York, where rents have increased while wages have relatively stagnated, is for people, it affects people with serious mental illness the same way, in part because it reduces the supply of open apartments that could then be converted to scattered site supportive housing. And when there is less scattered site supportive housing, then there's less congregate supportive housing. And often when you're coming out of transitional housing or shelter, you need to go to a permanent supportive housing um, site which has on-site services. And so there isn't enough movement and not enough dynamism in the system because there's just a lack of supply. So couldn't agree more. We need to build more affordable housing and open up more supply so that we can build in turn more congregate and scattered site supportive housing, permanent supportive housing.
And just add to that, the issue that often people with serious mental illness face in terms of trying to find low-income housing is that they're competing with all of the other poor people in the communities for low-income housing. So having set aside specifically for people with mental illness is really important. The next question is anonymously sent in. And the question is, how do you justify the risk that comes from calling 911 and involving law enforcement, particularly for people of color experiencing mental health challenges?
I don't have a clean answer to that one. You know,
Good
we
one.
don't have another crisis response system. Not really. I pushed hard to advance 988 in this country. I'm sorry, in the city when I was health commissioner. In fact, to the extent of getting rid of and streamlining with NYC Well. NYC Well was a bespoke hotline that we created, but didn't have all the other access to other resources that the federal hotline created. And so I not only made that the single hotline, but also got the state to put in resources to back that up with services and technology and supports. And now the new administration has cut funding for 988 and for SAMHSA. So I don't know. I don't right now 911 is all we have for in the main. And that is a very tough place to be. That is a very tough place to be for the dispatchers who have to make very, very difficult decisions on who to send. It's very tough for the person calling, not only to adequately describe what's going on, but to keep the person in crisis safe, to keep themselves safe, to manage the situation, which can be very, if you've ever listened to some of those 911 calls, and I've sat at EMS HQ and listened and watched them work through these calls, extraordinarily challenging. And then, of course, it's challenging for the response teams, especially if there's no co-response, if there isn't a clinician or a social worker or a peer accompanying that police officer. That's a recipe for not a great outcome in general. So I don't have a great answer how you justify the risk, but I would say that we need to invest more in alternative responses. And 988 should be a place where everyone feels they can go when they have when they or themselves or a loved one has a mental health need.
Unfortunately, we're at time, even though there are a few more questions popping up. I think we're going to have to stop. So thank you so much, Ashwin. And thank you all to everyone who has submitted questions. Sorry we couldn't get to them all.
Yes, no, I want to thank both Dr. Vasan and Lamel for today's discussion and for all the great questions. I did see so many. You've given us so much to think about, so we're incredibly grateful. The recording of this event will soon be posted on the Columbia Division of Ethics website. So if you need it as a resource, it will be there. And for others who haven't been able to join us, please let them know. We hope that you will join us again when we resume Ethics Grand Rounds in the fall. In the meantime, there should be links to subscribe to the mailing list so that you get the details for the events coming up. There will be a survey, and we really take your comments seriously. So please do fill it out and let us know if you have suggestions for topics and speakers and just general feedback. Thank you again for joining us. Thank you so much, and we hope to see you soon. Have a great week, everyone.
Thank you.
Thanks so much.
Thank you so much, Ashwin and Stephanie. That was terrific.